thank you for joining early. This is, I know, difficult for some people, but those who have joined, I'm sure they are more motivated. So I shouldn't waste their time and start it straight away. This lecture, which I was asked to give in Singapore. So this is something which I'm repeating in a sense, but they asked me to present on how do I teach sample size calculation. So I told them that, look here, traditionally, if you attend a statistics class for sample size calculation, you will have formula like this, which frightens me. I am, in fact, terrorized by this type of equation. I don't know whether you are, this type of equation. So it was a nightmare for me. So I started working on it to simplify. You see this alpha, gamma, delta, and sigma, and all that. So I have simplified it. This simplification is good for clinicians because they often want this to be done on the back of envelope anytime, sitting anywhere in the rounds. They may like to do calculation and see whether it is feasible to do a randomized trial on a topic or not. Our residents get very good idea about what are the topics, but because they are there for 3 years, they are not feasible. So I'm going to start with something which will require only addition, subtraction, multiplication, and division, not more than that. So you don't have to know more math than simple, which you learn in grade 2, grade 3. I'm going to start with randomized control trials, then go to cohort study. So suppose you wanted to do a randomized control trial where you plan that you will have 2 groups. The 2 groups will be parallel. There is something called crossover trial where one group receives treatment A, another group receives B. After some time, you stop both and give a washout period. Then the group receiving A starts receiving B, and the group receiving B starts receiving A. That is called crossover trial. We are not talking of that because here we are talking of a topic like surgery. You can't undo surgery after you have done it. So most of the questions which you will deal with are not suitable for crossover trial, but they are suitable for what is called parallel group trial, where they don't cross. So something which doesn't cross, you remember that word parallel means 2 lines which never meet. So these parallel groups never meet, they don't cross. That is why the word parallel. Suppose your hypothesis is that in patients with hypertensive brain hemorrhage, surgery reduces 30-day mortality from 40% to 20%. Now you will say, how did I get 40%? And how did I get 20%? Now this is 40% is known to you because before surgery started, lot of patients have had this and you have seen them, followed them, and within 30 days, 40% are known to die. So these are based on studies which are done on, let's say, case series, natural history studies, or observational cohort study, where you already know that 40% people die. Then you are thinking that if surgery reduces this by 20%, means 40% becomes 20%, then only it will be justified and it will be useful, it will be acceptable for both the patients as well as surgeons. That 20% is what we call possible benefit, plausible effect. So plausible effect is 40 to 20%. It should be clinically important as well. Otherwise, even if you do the trial and you show difference, suppose there is difference of 1%, nobody will go for surgery. 40% to 39%. There is so much hassle in surgery and risk also in surgery. That 1% difference will not be persuasive enough for patients or surgeons to go ahead and do it. So 20% difference which you see here is something which is hypothesized, something which is plausible, something which will be clinically important. So it is just an example. You may think 5% is also clinically important, 10% is also clinically important, but just for an example, I have taken this so that we can go ahead with calculation. Which means what we are saying is with best medical management alone, 40% people will die in 30 days. Let us call it PC. C I have added because this is the control group. Whereas the intervention group, their surgery is also added to best medical management, which means these people are exposed to surgery as well as whatever best medical management is possible. Suppose their mortality is 20%. So I called it PE. E stands for exposed, C stands for control, but I think later I have called it PO because means P0, no intervention. So P C or P0 is interchangeably used in my presentation. So percent of people who die with exposure to surgery is 20%. So and those who die in the control group are 40%. So what is the average? Average is 30%. That average I have called as P, right? So P is average of PE and PC in this case. Now, what is the difference between these PE and PC? 40% minus 20% is 20%. Let this difference be called D. Why am I calling P and D? Just so that I can write a simple formula. So now you know P, you know D, and then if it is, and it is superiority hypothesis, surgery is superior to medical management alone, then remember average of PE and PC is 30%, difference between PE and PC is 20%. Now you have the formula, 16P 100 minus P divided by D square or D into D. So in a class, I ask people to do this calculation, but I will do it for you. 16 into P is 30 and 100 minus P is 70. So 16 into 30 into 70, which and divided by 20 into 20. D is the difference, 20 into 20. So if you cancel 0, 0 here, then you can see that these 2 are 4, 4 are 16. So 4 into 3 into 7, which is 84. And this gives you sample size per group. It is not for one group. So since you have two groups, total sample size will be 168. So that's as simple as this. Now, when I started presenting in some of the classes, they said it's so easy that is it published? So what reference we will give? And just to let you know that I have published this. This is in National Medical Journal of India. And if some of you want to do it, you can get it from the site of National Medical Journal. So this is what the sample size calculation is for a randomized trial with superiority hypothesis. Remember, this can be remembered once you practice it a few times. 16P into 100 minus P divided by D into D. So this is for a study with two equal size parallel groups. And what is P? Average of PE and PC. D, the difference between PE and PC. So that's it. Now you have to do some exercise before you really get this into your mind. So suppose this is the you want to do a randomized trial with this hypothesis. Dexamethasone adjunctive therapy reduces mortality from 15% to 5% in children with neonatal meningitis. So what sample size will be required? Now here I will allow anyone who is able to calculate quickly to come up and tell me what answer they have got. I'm also going to do calculation. So Ravi, you can allow people to unmute and speak.
Yes, sir. They all are unmuted, sir. They can unmute themselves.
Right.
144.
Right. Correct. So 144 per group. Remember, 144 per group.
Yes, sir.
Right. So total sample size will be 288. So this is the formula, and as simple as this. Now you can keep practicing, and you will get better and better. Now I'm going into the cohort study. So cohort study is basically something like this: that you have a patient population, and I'm doing this because most of the residents, most of the clinicians, if they don't have money or let's say set up to do randomized trial, they can do cohort study. In cohort study, let's say we have COVID patients. In the normal treatment course, and Ravi, you can now mute people so that there is no disturbance. I will tell you when to unmute. So there is exposure group. Let's say some people wanted to see whether statin use in patients with COVID-19 reduces mortality or not. So there is exposure group. Exposed group is taking statin, and unexposed group not taking statin. Then you follow them up to find out outcome. In this case, let's say death and no death in the exposure group, and death and no death in the unexposed group. And then you find out the percentages and compare this percentage. And usually what people use in cohort study is risk ratio, also called relative risk. Relative risk is proportion of exposed having the events. Let's say, as I said, in this case, death is the event, divided by proportion of unexposed having the event. I told you this is like a control group, which I am going to use. Not exposed means zero exposure, so P naught or P0 or PO, and relative risk is nothing but PE divided by PO. So that is the relative risk. In cohort study, you have to hypothesize what is the relative risk you want to detect. You see, in the randomized trial, we said what is the difference you want to detect. Here, people will often like to see that what is the relative risk you want to detect. Now, so in one example, for you can see here, the relative risk which they wanted to detect is 1.18. So statin use in this case had actually 18% increased risk of severe COVID infection. So 1.18. Now, we know that incidence of mortality in unexposed group is 20%. That we know from previous study already published, or maybe a case series where people have looked at mortality at certain point of time. So 20%. And relative risk you want to detect is 1.18. Let's take 1.2 for the sake of simplicity. And then you have 1%, which is PO, this is the control group. Remember, like I use the word PC in randomized trials, that is 20%. Now, what will be if they are exposed? So you have to multiply P0 with relative risk. So basically it is saying that those who are exposed, they will have 1.2 times mortality or 20% more mortality. So you have to multiply 20 to 1.2, which gives you 24. So 24% is the second one. What is the average of the two? 24% plus 20% divided by 2 is 22%. And so you know the P, and you know the difference, which is nothing but difference between those having events in the exposed group minus those who are having events in the unexposed group, which is 22 minus 20, which is, no, it's actually should be 24 minus 20. Amit has done it. There is a mistake here. So it will be 4. And now you have the D, you have the P. You can apply the same formula and use it. It will be 4 into 4 years. So actually, this will be divided by 16, and you get the samples. Take another example, like this is a meta-analysis of cohort study. And you can see this relative risk of 2, which was the relative risk to be detected. So you can see here, 20% suppose die in the unexposed group, and your hypothesized relative risk is 2, which means P by PO is 2, which is, if you want to know what is the proportion in exposed who will die with relative risk of 2, it is very simple. 20 multiplied by 2. So 40 is this, average will be 30. And the difference between 40 and 20 is 20. So D is 20. PE minus PO. PE, those who are exposed to, in this case, probably kidney injury. So that is 40%. Those who are not exposed, 20%. So difference is 20%. And average of the two percentages, PE and PO, is 30%. So if you apply the same formula, 16P 100 minus P divided by D square, it will give you 84 per group. So that is what becomes the sample size per group, which means you need 168 patients to do this. Now, when I said this, and then I told the Singapore population, so thank you very much. My lecture was finished in, as in this case, in 15, 20 minutes. And then I asked them any question. So somebody came up with the question, which some of you may have also in mind. So they asked, where does this 16 come from? And I said, okay, if you want to know this, then you have to take a test from you. I said that what I got 16 from is, in India, for years there is mythological history which says that whenever somebody is terrorized, so there was a story that all the gods were terrorized by demons, and then the head of gods, Bhagwan Indra, goes to Himalayas and does a tapasya for some years so that Brahma is pleased. And then he says, what do you want? And he says, look here, we want to kill the demons. They are terrorizing us. And then Brahma is so pleased to give him the blessings. And then the problem is solved. So I told them that I was terrorized by this sample size formula. So I also went to the Himalayas and did some, tapasya for some years. And then God was pleased and said, look here, to solve your problem, this is the word number 16, which will solve your problem. This is where I got the 16 from. So everybody was very, I would say, happy to know this mythology. But then I had to say that, look here, there is some reason for getting 60. So I said, I will take your test. And the test is related to diagnostic test. You know that when we want to diagnose disease, like disease present, disease absent, we use some gold standard. You have to evaluate a test against a gold standard. This is the candidate test, also called index test. And you want to know how good it is compared to the gold standard. So test reports will be positive or negative. And gold standard will tell you disease present or disease absent. So if test is positive, and in truth, as revealed by the gold standard, disease is present, then what do we call it? We call it true positive. If test is positive, but disease is absent, then what do we call it? False positive. Because disease was not present, but your index test was positive, so it is false positive. If test is negative, but disease is present, so this is false negative, because it should have been positive, but it is negative, so it is false negative. If disease is absent and test is also negative, that we call, true negative. So this every medical student knows, every resident knows. There should be no problem in understanding this. These are the various results of a test: true positive, false negative, and true negative. Let's take an example. Suppose you have done a study with 400 people. 200 have disease, 200 don't have disease. This is hypothetical example. Test is positive in 190 among the diseased patients, and test is negative in 10 who had disease. On the other hand, 160 of those who didn't have the disease are negative, but 40 are positive. So as you can imagine, these 190 is true positive, 40 is false positive. Positive but disease absence, false positive. 10 are false negative because disease is present but test turned out to be negative, and 160 are true positive. So these are the various kinds of results, right? Now, if you convert that into percentages, it comes to 190 out of 200 are positive, 95% are positive, 40 out of 200 who don't have the disease are positive, so 20%. Similarly, here 5%, here it is 80%. So once you convert the numbers into percentages, this becomes proportion or probability. So proportion, percentages, probability, all are similar with slight differences. Proportion is usually given in decimal, percentages are given like this, and probability tells us what will happen in future based on the results which we have observed. So some people call it true positive rate, false positive rate, false negative rate, and true negative rate. These are also given in textbooks, many textbooks, but these are not actually rate, they are probability. So in our example, you have seen true positive, false negative, true negative, and then converted them into what people call true positive rate, false negative rate, and true negative rate. So remember, these are types of results and these are various probabilities. That is what is to be remembered. They are not the same thing. These are types of results. These are probability of various results. And if you remember your lessons on diagnostic test, this probability or true positive rate is also called sensitivity. The true negative rate is called specificity. I'm sure you know this very well. Now, I would like you to remember what is the relationship between false negative rate and sensitivity. So true positive is here, false negative is there, sensitivity we say all the true positive rate is sensitivity. So remember this column is important. And when this false negative is 10%, true positivity or sensitivity will be 90%. If it is 5%, sensitivity will be 95%. If it is 10%, sensitivity will be 90%. So sensitivity and false negativity or false negative rate has got this relationship. So why did I tell you? This is because a study is also like a diagnostic test. The difference is study is trying to diagnose the truth about whether a treatment works, whether surgery works, whether statin decreases or increases death. These are the truths which we want to discover through a study. Unfortunately, there is no gold standard to reveal the truth in this case. It is known only to God. But however, study tries to find out what is the truth. So study finds, suppose that the new treatment works, which means it makes a difference. Whereas truth about the treatment is that it may work or it may not work. Now, same as diagnostic test, if your study says that treatment works, means sometimes people call it positive study, and truth is that new treatment works, that is true positive results. So you have got a study which gave you right result which is positive, and in truth also it works, so it is true positive. Your study may say that treatment works, but in fact it doesn't work, which will be false positive result. Or your studies may say that treatment does not work, it does not make a difference, but in fact it works, so that is a false negative result. Or your study may say it does not work, and truth also is that treatment does not work, so that is a true negative result, just like you did in diagnostic test. Now, so these are the four possible results, four possible types of results. your study may be true positive, false negative, true negative. Even though this dichotomy is too simplistic, but it is good for understanding some concepts. So where do the errors occur? Errors occur if your result of the study is false negative, or error of your study result of your study is false positive. These are the two errors. So we could call it false positive error and false negative error. Now these are the two errors, and remember these are two types of errors: false positive error, false negative error. Now what our forefathers in statistics have done is they have called false positive error as type 1 error and false negative error is type 2 error. So I asked one of our statistician friend, why did you call it type 1 and type 2 error? Just leave it like false positive error and false negative error. And the reply is that, look here, we have to make some questions for the exam. So now that we have named it type 1 error, type 2 error, we have something which we can ask in exam, and those people who don't remember, we can fail them. So if it is so simple as false positive, false negative, where is the question? Everybody knows what it means. So this is the reason we have named it as type 1 error, type 2 error. Probably not exactly like this, but this is a trend in, our, let's say, every branch of knowledge, that we want to complicate things. So type 1 error, type 2 error is, this is how you remember. False positive error is type 1 error. Type 2 error is false negative error. So these are the possible results. Now results are known, not same as rate. So you remember type 1 error, type 2 error. You may often wonder, why can't we have a study with no error? No, that is not possible. Not possible because there is always a probability that you may land up in wrong results. So from the type of result, you can come to probability. Same as diagnostic test. From the type of results, we talked about true positive rate, false positive rate, by converting the numbers into percentages. So here you can, as I said, you can call it probability, false positive error probability, false negative error probability. So what is false positive error probability? Probability that your study shows that treatment works, which means it rejects the null hypothesis, whereas in fact the treatment doesn't work, which means it doesn't make any difference. Null hypothesis is true; it doesn't make any difference. But your study rejects that, so you land up with false positive error, and false negative error is probability of getting a result that treatment does not work, whereas in fact it works. So these probabilities are after you convert the type of result into percentage. Remember this. So once you convert it into percentages, then there is another name which has been given to this. False positive error probability is called alpha, just to make it perhaps shorthand, and false negative error probability is called beta. So this is what you ought to remember. What is alpha? Alpha is not false positive error. Probability of false positive error, probability of type 1 error is alpha. And probability of false negative error, which is also called beta, type 2 error, probability of type 2 error is called beta. Now, why do you need to know this? That if you don't want to use my formula, you can go to internet. There are many sample size calculation formula, but they will ask you, what is your alpha, what is your beta? So this is why you ought to know this. So type of result is false positive, false type of error is false positive error, false negative error. Type 1 error, type 2 error. Probability of that error, if it is false positive error, is called alpha. Probability of false negative error is called beta. So I must tell you that when I was a resident, I went to our professor of biostatistics to ask can you tell me what is the sample size? He says, how much type 1 error, type 2 error you are willing to accept? I said, I'm in All India Institute of Medical Sciences. I want no error. Why should there be error in my study? He says, you better go and attend my lectures first. You don't have any idea. So when I started attending lectures, then I came to know what is type 1 error, type 2 error, alpha, beta, and inevitability of some error which you have to incur whenever you conduct a study. So he said, okay, so now you know it. So how much type 1 error you want to accept? I said, what you have said, whole world accepts 5%. So I will also accept 5%. He says, okay, good. Now you have reached somewhere. How much false negative error you want to accept, or type 2 error? I said, to be balanced, let that be also 5%. He said, you get lost, you don't know, you haven't understood my lecture, you attend some more lectures and come back. And then I attended and learned that nobody takes 5% as false type 2 error or false negative error. Usually they take 10%, 20%, a little bit more, let's say, resourceful studies will take 10%, but hardly ever you will find a study, rarely you may, which you take false negative error or type 2 error also as 5%. So remember, alpha is usually taken as 5%. So every whole world accepts it. Nobody is going to ask for it. This is not same as p-value. You are still not conducted the study. You are doing sample size calculation. So you are budgeting for false positive error probability, which is 5%, which is alpha. When you have completed the study, and then when you see what is the probability that my study may be false positive, that is p-value, which is, as you know, we want less than 5%. But you are planning the study at that stage, you call it alpha, you call it beta. So remember, I told you to remember what is the relationship between false negative error and sensitivity. Again, to remind you this slide, that if false negative rate is 5%, sensitivity is 95%. If it is 10%, then this is 90%. When it is false negativity is 20%, then sensitivity is 20%. So same thing will be here. True positive probability, which in diagnostic test we call sensitivity, has some relationship with false negative error probability, which is beta. So this true positive probability is called power of the study, which is nothing but a complement of false negative error probability of beta. So if beta is 5%, I would have asked you in a lecture what will be the power. That will be 95%. If beta or false negative error probability is 10%, then power is 90%. If this is 20%, beta is 20%, then power is 80%. This is what you ought to remember. And I told you that type 1 error or alpha is often accepted worldwide as 5%, and type 2 error as 20% most of the time in residence thesis. Dr. Kumar Beli was asking how much should we take. 20% is acceptable. But if you are doing a company is doing a drug trial, they don't want to miss the true effect of the study, they may take 10% beta. Still more stricter may take 5%, very rare. So remember, probability of false positive error called type 1 error is alpha. Probability of false negative error called type 2 error is beta. Almost always alpha is 5% and beta is 20% or 10%. And I have already told you, and I would have asked in a class, if it is 20% beta, then power is 80%. If beta is 10%, then power is 80%. So this 16 which has come, each for alpha of 5%, beta of 20%, and power of 80%. And remember, they are equal sized groups. So allocation ratio is 1:1. And these are parallel group study. So if you have these parameters and you want to enter it in a computer or calculator, 5%, 20%, power means power of 80% with equal allocation, you will get same result or very close result to the numbers which you get from my formula. And I should tell you that sample size calculation is an estimation, is a guess. Often studies are wrong in that guess. That is why they have to stop study before it completes sample size. If they do interim analysis, they found better effect than they estimated. So they have to stop the study. Sometimes they have to prolong the study because they didn't get as much effect as they wanted. So these are estimations. So few numbers here and there doesn't matter. So for example, this is study of randomized trial. You see, they have done a sample size calculation, and I'm not going to cover this today. But if people want to know how does 16 come, then I will have to take you through all this and come to 16, which I'm not really sure how many of you want to do it. If you want to do it, we will do it next time, because I know there will be some questions in this. So if there are any question, I'm willing to take. If you don't have questions, then some questions I have, which I will ask you. So Ravi, you can allow people to unmute and ask questions.
Sir,
Comments.
Dr. Jayaprakash this side.
Yes.
Sir,
Go ahead, please.
you showed that one slide of risk ratio, sir, of one meta-analysis.
Yes.
Yeah, sir. Actually, that slide, Dr. Amit changed that. Sir, in most of the meta-analysis, in few meta-analysis, I have seen that a study sample, in a study, particular individual study, it was given in odds ratio. But on the meta-analysis, it was in risk ratio. So, two articles I have read that you published that what are relative risk number needed to treat and odds ratio, that published in Annals of Neurology, Annals of Indian Academy of Neurology, and one article that tips for teachers of evidence-based medicine, that published in Journal of Internal Medicine.
General Internal Medicine. Yes.
Yes, sir, with Gordon Gatt, Dr. Gordon Gatt.
Yes, yes. I have published that. This is today's topic is not about odds ratio, because we explain odds ratio and its relationship with risk ratio. I need.
My simple question is that is it good to convert that odds ratio in risk ratio when we are doing any analysis?
Risk
What is the
ratio.
validity?
Risk ratio is preferred mainly because most people can understand. For example, as I said, if risk of mortality without statin is 30% or 20%, and
Yes,
relative risk is 2, that means with statin it will be 40%. It may be the other way around. If the relative risk is 0.5, that means 20% will become 10%. Easy to understand. Odds ratio is not easily translatable like this. It is not easily interpretable by clinicians. So people often, they have written papers that odds is something which gamblers can understand, but those who don't gamble, they don't understand. You know that people let's say put bets on which team will win, Indian team or Pakistan team in cricket. They often talk about odds, but odds of India winning is against Pakistan is 3:1. So that is, they are talking in terms of odds. Odds is not something which commonly people interpret in clinical medicine. So preferred measure is relative risk or risk ratio. But odds ratio is the only one measure which can be used in case control study, and is also popular because logistic regression is equation is set up like this, that it gives odds ratio. So there is no problem if you are doing a randomized meta-analysis of randomized trials. You can use either risk difference or relative risk or risk ratio or odds ratio, whatever you want to use. Cochrane collaboration prefers you use risk ratio, but many people use odds ratio. That is something, a different topic related to meta-analysis, why they use it and can we convert one or the other, but you can use any one of these. If you are doing a meta-analysis of case control study, then you can't use relative risk or risk ratio. You have to use odds ratio. Any other question?
Sir, one question, sir, about sir, there was a question also in the chat box about we keep getting this term non-inferiority trial. What does it mean?
Right.
So,
non-inferiority trial is to understand that best. I'll ask a question in my class that there are studies which correlate IQ and gender. So I ask people, what is your hypothesis? What is the results of the studies? That I will tell you later. But what is your hypothesis between IQ and gender? And then, some boys will say that males have higher IQ than females, and girls will say that girls have higher IQ than males. So there will be somebody who will be moderate and he will say girls have no less IQ than males. Now these are, you can say, some people will also say girls have the same IQ as males. Now these four statements are for, you can say, three different types of hypotheses. One group having more IQ than the other is superiority hypothesis. Equivalence hypothesis is when you say that IQ of males is same as IQ of females, or the other way around, IQ of females is same as IQ of males. That is equivalence hypothesis. But if you say it's something like this, IQ of females is not less than that of males. That is non-inferiority hypothesis, because you are saying females are not inferior to males. That doesn't mean they are same. It is possible that they have higher IQ than males, or they have the same IQ as males. These two things are possible. But if you say females have no less IQ than males, this statement is a non-inferiority statement. So same thing happens in treatment. Treatment A is better than B. Treatment B is better than A. These are superiority hypotheses. Treatment A has same effect as B. That is equivalence hypothesis. But if you say treatment A is not inferior to B, means it may be better, but you are not interested in knowing that. You want to know that it is not inferior to B, non-inferiority hypothesis. So the difference is, when you say superiority hypothesis, you have to only test whether it is better or not. You are not bothered whether it is worse or same. If you are going for equivalence hypothesis, you are testing, is it better? Is A better than B, or is B better than A? So you are testing both sides. That is also called two-tailed hypothesis. But if you are asking only whether treatment A is not inferior to B, you are only interested in showing that it should not be worse than B. It may be same, it may be superior. You are not interested in that. So that is non-inferiority hypothesis. So you will design a non-inferiority trial for this. It will be one-sided test. That is the difference. But some trials are designed so that they can test both non-inferiority, and if they show non-inferiority, then they will test superiority as well. So the sample size calculation will differ between superiority, non-inferiority, and equivalence hypothesis. I've not covered non-inferiority today, but next time I can cover some more issues in sample size calculation if you are interested, including non-inferiority. Does that answer your question?
Yes, sir. So one more question is that when we are doing a cohort study,
Yes.
as you have said that in stroke or whatever be the condition, there
Yeah.
will be multiple variables,
Yes.
the two groups.
Yes.
So we keep seeing in the studies, no, sir, that multivariate and univariate, if that could also be highlighted to us.
Very good question. So suppose you want to see, let us say, what are the factors which are related to poor outcome in stroke, for example, right? And let us say 40% patients are having poor outcome and 60% patients are having good outcome. So if your outcome is like this, dichotomous, poor outcome, good outcome, death, survival, remission, non-remission, we call this as dichotomous outcome. Then first thing you have to ask is, which outcome is less frequent? So in this stroke example, which outcome is less frequent? Good outcome or poor outcome? As we said, 40% have poor outcome, 60% have good outcome. So less frequent is
Poor outcome.
poor outcome, right? So if poor outcome, whatever is less frequent, you take that as basis of sample size calculation. And you have to take so many patients so that there are at least 10 cases with poor outcome per variable which you are going to test in multivariate analysis. So if it is poor outcome, then 10 patients having poor outcomes would be in your study to test one variable of interest. So if you have 10 variables of interest, that means you need 100 people with poor outcome. To have 100 people with poor outcome, obviously that will be 40% of your sample, which means you have to have 60% add to that, which will be what, 100 and
By 40 into 60.
yeah. So you have to have, let's say if you have 200 patients,
300, sir. It amounts to
you have
around
200.
166. 166.
So if you have 200 patients, 40% means 80 patients will have poor outcome. You can test 8 variables with that. So remember, it depends on how many variables you want to test. And then if you have 300 patients, 40% means 120 will have poor outcome. You can test 12 variables in that. So you have to ask how many variables you want to test, multiply that by 10, and that many poor outcomes you have to ensure in your cohort to be able to use multivariate analysis. That's a very simple formula, isn't it?
Yes.
So that is what they should do.
Good morning, sir. This is Abhishek. I have a question to ask, sir.
Yes, Abhishek, go ahead.
Sir, say if we are planning something very novel, which has not been reported in literature, so is it always important to have a pilot data to calculate the sample size, or is there a magical number like 30 where we can say for a new trial or new intervention that we are trying that it is good enough? And second thing is just a small comment on proof of concept study and the number for that study, if any.
All right. So first thing is, if you have no idea, then there are two options. One is that which will be, I think, desirable option is to have a pilot study first. But if you have good reasons to do a big study straight away, I don't know, that may be true for something like vaccines, new vaccine coming up or something for COVID-19. Then imagine if it is 16p into 100 minus p, there is a limit to which this numerator can go, isn't it? Because the largest sample size will be 16 into 0.5 into 0.5. Means 16 into 50 into 50, right? Because it can't go beyond this. Remember, if it is 16 into 20, then 100 minus 20 will be 80. 16 into 20 into 80. If it is 90, it will be 16 into 90 into 10. But maximum will be 16 into 50 into 50. So if you have no idea at all and you want to do a large study, use the numerator as 16 into 50 into 50, and the denominator, whatever is the difference which will convince people to use this intervention. So with no idea, you have to have big study. So suppose you think that this treatment will make 10% difference, but I have no idea what happens without this treatment. So take 16 into 15 into 50, 40,000 divided by 100. So 400 per group will be something which will be maximum. You don't need more than that. If 10% difference is what you want to detect. So if you have no idea, take the maximum, which is 40,000 divided by square of the difference. And that will give you a sample size which nobody can challenge. Now, proof of concept studies, they are like pilot study, and very rarely they are randomized trial, but they can be randomized trial also, small studies with, and I will tell you, you better take an outcome which is not dichotomous, because that requires usually more sample size than outcome which is numerical. Like if you want to reduce HbA1c in diabetic patients by using garlic, for example. Now, the HbA1c is expressed in percentages. It is not a dichotomous outcome. So you want to dichotomize, you can dichotomize like less than 7% and 7% or more. So that is another way. But if you want to use numerical, can I bring down the percentage? Then it is called continuous outcome. Continuous because it can be 7.1, 7.2, 7.25, whatever it is. So it's a continuous numerical outcome. That I have not covered, so I will cover it next time, taking cue from the question you asked. Proof of concept studies usually take continuous outcome. So next time I will take continuous outcome and again give you a simple formula for calculating sample size, which will be depending on large effect, it will be 32 per group. If it is moderate effect, it will be 64 per group. If it is small effect, then it will be, I think, around 400 per group. So I will illustrate that next time.
Thank you, sir. Thank you so much.
Any other question?
Good morning, sir.
Prasad.
Good morning. Nice to join your class, sir.
Yes,
Uh,
yes.
Just wanted to ask you, maybe you are going to cover it in the next one. So otherwise, you can just tell. I was just wondering on this confusion of equivalence versus superiority versus non-inferiority trials.
Yes.
Suppose everyone just do a two-tailed equivalence study, then won't it always give everybody all the answers that they are looking for? Or is it too high a sample size, which would make things practically too challenging? That's why we are going for other forms of trials.
You are right. One-tailed study gives smaller sample size than two-tailed, but that is not to say that people often do one-tailed test only. But yes, non-inferiority trials, you see, to demonstrate equivalence, in very strict sense, you are saying that the difference between A and B should be 0, right?
Yeah.
And you can imagine in denominator, D is the difference. If you put 0, then the sample size will be infinity.
Yeah. Yes.
So, which means people have to do huge studies to demonstrate equivalence. Now they have found out a way saying that, okay, a difference of 5% we will consider as if it is 0 difference. That is another way to do a study by just, let's say, reformulating your thinking. But true equivalence cannot be shown between any two treatment because you need infinite samples. So that is why people say, I can't demonstrate equivalence, but I can demonstrate non-inferiority. That is why non-inferiority is preferred. But superiority trials also use two-tailed test because your hypothesis is A is superior to B, but maybe it turns out B is superior to A. So you have to give both equal chance. So they do two-tailed hypothesis, but For superiority, it is not a problem because you have some hypothesized difference which you put in the denominator D. So it always gives you manageable sample size. But for equivalence, if you are reducing the difference to 0% infinite sample size, then people say 1% I will ignore. Then you get some sample size. Then gradually you will see that truly equivalence studies are not possible, but those who do it, they hypothesize or ignore a difference which clinicians perhaps are not willing to ignore. So we'll do that. But since nobody asked this question, because I have told you for 80% power, nobody said what if we want 90% power. So I have to give you that because that will complete my presentation today. 80% power with alpha of 5%, the multiplication factor is 16. If you want 90% power, it becomes 21. And you can imagine, similarly for 95% becomes 26 and 99% 37. So 16 is for 80% power. Since 5% is acceptable, this column is what is commonly used. But if really somebody wanted to reduce alpha also, which is to make it 1%, then you can imagine how much sample size will increase. So that is one thing. Second thing, which nobody asked this question, is what if I want that control group has more number? Then you decide. This is, I told you that what you calculate is n, and you multiply it by 2, you get 2n. But if you want 1:2 in your 1 is like exposed group, 2 is or 1 is exposed group, 2 is unexposed, 1:2, 1:3, 1:4. Then you can change, multiply that n by these numbers to get those who are exposed, those who are not exposed in cohort studies. So remember, these two tables are very important. Deviations from my standard formula, but it can be by these two tables, you can get whatever you want. So in summary, we have covered what is type 1 error, type 2 error, alpha, beta, power. And as I told you that you can't have the real truth revealed to you, that only God knows, so God is great. Thank you. Any further question?
Sir, good morning, sir. Dr. Inder from Bikaner. I want
Yes,
to know
Dr.
the sample size formula change with the sampling study, like it is cluster randomized, or it is simple random, or it is multi-stage, like.
Yes. If cluster randomized trial, formula changes slightly because you have something added to that, which we will discuss some other time.
And the 16 also change with this if the variable is outcome variable is continuous.
No, that I will show next time that 16 remains 16. Don't worry about that.
Okay, sir. Thank you.
Any other question?
Good morning, sir. This is Dr. Ankita.
Yes, Dr. Ankita.
Suppose we have to go to study a rare cause and effect relationship in a retrospective cohort, and there is paucity of literature where calculation of P is a mere estimate, and I'm not very sure whether I'm going in the right direction. So in that situation, should I choose effect size calculation or the similar formula of 16P1 minus P, 100 minus P upon D square, sir?
So effect size comes in continuous outcome, numerical outcome.
Yes, sir.
I told you we'll cover next time.
Okay, sir. All right. Thank you, sir. Thank you, sir.
Okay, right. Thank you very much. So let's see how we can stop sharing. Right. So thank you. So next time, every time we are setting the agenda for the next time. So next time will be for continuous outcome. Thank you very much.
Yes. Thank you, sir.
Thank you, sir.
And we'd like to remind everybody that a copy of this recording will be made available to you. We'll post it on YouTube.